the word papilla appears so many times. And I mean, everybody here today had that on their mind. And I would like to show somebody who should definitely be here on stage, a young woman from Croatia.
For your idea, for your invitation. I'm going to talk to you about how to make papilla. Sometimes it can be done, like in this case. During surgery, it was very important to mobilize sufficient the papilla. I used the vestibular and the palatal access to mobilize papilla. Then the connective tissue grafts from tuberosity is introduced into this tunnel. Here we see some pushing and pulling at the same time and a nice gain of papilla volume. And situation immediately after surgery and after few weeks. In this case, there is a papilla atrophy between the central and lateral incisor. There is also horizontal ridge atrophy and there is a vertical root fracture of the central incisor. In cases like this, I often achieve nice results utilizing pediculated connective tissue graft. Not always, but often. Post-extraction implant placement with dual zone augmentation, harvesting of pediculated connective tissue grafts, some inserts from surgery, and here you see there are 3 soft tissue grafts, 2 free connective tissue grafts, and 1 pediculated connective tissue graft. Immediately after surgery and healing after 3 months, impression was taken and another soft tissue volume augmentation with free and pediculated connective tissue graft. 6 months after provisional delivery, nice emergency profiles, and the final situation is the partial extraction therapy. Look at this patient, the initial situation. This is what we have, and this is what we want to have. And papilla between central and lateral incisor determines the success of this therapy. Here some lateral views. To maintain papilla between incisors, I applied partial extraction therapy. Here we see a C-shaped socket shield to maintain papilla between 2 central incisors and especially between central and lateral incisor. And here is the patient with the provisional, already very happy. And here we see again the initial situation and the situation after definitive prosthetics. I finish with a pic from my partial extraction therapy Orlando group. Happy to be here. Love your Dental XP family. Thank you, Miguel. See you in Orlando.
So, I just thought that it's not fair that only a few guys get to stand here on stage when there's so many amazing people around the world just freely giving up their time. I mean, Snezhana, you could have been doing so many other things than documenting all of this, putting all of this together. So I reached out to a few of my friends, and we don't really know each other that well, but I met you on Dental XP. We met you on the forums, following you, discussions with Howie Gluckman, because that's the connectivity and what everybody was talking about, that we're all coming together for a common interest. This is Mario Steigman, who needs no introduction.
Hi, this is Dr. Steigman from the Steigman Institute in Heidelberg, Germany. I want to say hello to everybody at the Dental XP Summit in New York City. In 2008, we wanted to find another way to position the interproximal peak of bone in a more coronal position, and we used a bovine bone mineral block as a proof of principle to do that. Another way was described by Carranza in a natural dentition to correct the papilla by a connective tissue graft. So this was what we published. You see, in the interproximal peak of bone was raised with the use of a non-resorbable block. A resorbable block would shrink, and then the peak of bone will move in the more coronal position. So as a proof of principle, we realized that we can improve hopeless situation, aesthetic soft tissue improvement, by using a non-resorbable block with a vertical correction of the interproximal height of bone. But what we are doing in the last couple of years, we are using non-resorbable material to regain that papilla height. So when we have a big distance, more than 7, 8, 9, or 10 millimeters, we make a flap and we pack some resorbable material under the papilla height without destroying it. And then this material will resorb, and the soft tissue will not follow the resorption of the bone grafting. In this case, beta TCP. So we see when we finish a case, the distance from the interproximal peak of bone to the contact point is 10 to 12 millimeters. However, we can restore a loss of papilla with a different surgical technique, a tunneling technique with a corneal reposition of the papilla. We can go from here to here with a predictable way using materials which cannot lead to future complications.
So, what I wanted to share through these videos out there, there's hundreds and hundreds and hundreds of us out there dedicating our daily practices to solving this problem. There's no key solution. There is a lot of science, so we spend a lot of time going through the science, and I'm sure for every different problem, there's different ways that we can adapt these solutions. And the papilla, of course, is incredibly important, because I actually gave a TED talk in London at the SOAS University last November, because I wanted to share with people and impress on people how difficult it is to be a dentist sometimes, because this girl probably never thought of going to a dentist in her life. Probably just had a checkup or a bleaching, and she falls down the stairs, and this happens. How many of us can safely say that predictably we can get her back there 100% biologically 100% of the times? How many people can say that? And I've got the best in the world here. I don't know how many people can say that. So, of course, what is considered an aesthetic smile? We have the smile line coinciding with the line of the inferior lip. And of course, we've got all the science up in the top left corner. We have minimal gingival exposure. We have the thickness of the lips. These are the basic things that we can see in day-to-day practice. And of course, we have some other things. We have adequate gingival contour, symmetry and proportion between the central incisors, moderate to minimum buccal corridor spaces, minimal gingival display, and curvature of the maxillary anterior incisal edges parallel to the lower lip. So no matter what problem we're presenting with, we always have to find the end game, the big picture, as Dunis said. So we have to think what is going to be the final restoration before we actually head for the soft tissue. So here are a few examples of people that work with me of what we would consider nice smiles. So they're all different. We have the curvature of the maxillary incisal edges, the symmetry and proportion between the central incisors, minimal gingival display. And this is what we're always going to look for time after time. And for those of you that know my philosophy, no half smiles, it's pretty much you don't restore a smile unless you restore the whole smile. So partial tooth dentistry, no matter what, if a patient's got an ugly smile and you spend hours and hours restoring just one papilla, but the rest of the smile is ugly, at the end of the day, you're not going to have a happy patient. And of course, the moderate to minimal buccal corridors are also important to keep in check. The adequate gingival contour is also incredibly important. So a closer to ideal relationship between the teeth and the respective papillae can be established to achieve optimal and optimized aesthetics. Gingival trait with a pyramidal shape that occupies the spaces between two adjacent teeth, and that is what we are looking for when trying to get a perfect solution, a perfect endgame. And according to the studies, Tarnow in 2009 said basically the papilla will occupy around 40% of the entire length of the tooth. So this is just some of the foundations for what we are doing. And of course, it acts as a biological barrier, protecting the periodontal structures, and plays a critical role in aesthetics. This is very, very important. So the foundation for the gingival support is the underlying contour of the osseous crest. Everybody knows this. It's been discussed many, many times over the past few days. So in terms of histology, I think you might all be very bored of this because it's been repeated over and over again, and everybody knows these numbers, and they have to be respected. And of course, it is something that is very fragile. It's something that is elusive, and sometimes we can really spend a lot of time working on getting a papilla, and it disappears, it loses. So it is something that we have to handle with a lot of care. So what factors will influence the presence or absence of dental papilla? Well, bone level is probably the most important and recognized factor. So Tarnow in 92, of course, he understood that over 98% of the times when we had 5 millimeters or left, we had papilla, and that number would decrease. I actually wasn't 100% certain of this in my day-to-day practice, so I'm very happy that I had to go back and study. I didn't know that 27% of the times, if you have 7 millimeters, you might have papilla. Because I was always fixed on just the 5 millimeters. So sometimes it's really good to go back and read the literature. So I'm really grateful, Mo, that you made me do this, because now I know that sometimes, you know, in 56% of the time, 6 millimeters between aesthetic teeth, we can get the papilla. Now, I've lectured in 50 countries around the world, and I have always asked people if they know about this study from Tarnow. And you would be surprised at how few dentists who actually do restorative and cosmetic dentistry do not know that study. And it's kind of scary if you think that these people are actually treating patients, and one of the greatest concerns for our patients is an aesthetic smile, and that this simple biological study can actually help really, really simplify our treatment options. Of course, number 2 to get a papilla is the presence of adjacent tooth attachment. So when we don't have teeth that are adjacent, we will not have a papilla. This is pretty logical. And in this case, we just did a bit of Invisalign, brought those teeth together, and there you see the papilla. So number 3 is volume of the gingival embrasure. So of course, if we don't have that as well, we will not have the papilla. And in this case, we had a patient that didn't want to do Invisalign, and didn't have a lot of cash to spend. So just with a little bit of composite, we just closed that gap according to the literature, and we got an improved papilla. Maybe not perfect, but improved. So other factors that will influence the presence or the absence of dental papilla: soft tissue appearance. So flat is better than pronounced, and high scalloped, of course, from Salama. You guys really have been focusing on papilla for a long time. Like, seriously, like a long time. Really, it's amazing. I mean, to see your names pop up over and over again, and then so recently with the partial extraction therapies as well, that you've never stopped looking for this, the Holy Grail or the Philosopher's Stone, you know. Of course, the thickness of the buccal plate, as we saw today in Alain Simon Pierre's lecture, who was very, very focused on having that. And of course, the tooth shape, where we know that triangular crowns have small proximal contacts located near to the incisal edges. Square-shaped teeth have longer and more apically positioned contacts, and as a result, less tissue is required to fill the interproximal spaces. So this is very important when you're doing single implants in the aesthetic zone, is to actually understand the anatomy of the adjacent tooth before you go in. So as I progress in my career, I'm spending more time prepping than I am working. And with digital technologies, that's pretty much taken over. I mean, the thinking, the thought process, the architecture, the design, the interdisciplinary approach, who does what when, and knowing everything before you go in is paramount importance. So here are a few cases that we solved in a simple fashion. And this patient, she complained of not having an interdental papilla here in the aesthetic zone. And she was quite a complicated patient, and we discussed orthodontics. We discussed, as we'll talk about this in a bit. We discussed orthodontics. We discussed many, many other things. She needed some implants, some guided bone regeneration. She needed a lot of comprehensive treatment, which would be the gold standard protocol. But I've learned that my job is mostly avoiding stress for myself and my team. People ask me, what's your job? You know, aren't you a dentist? I say, well, my real job is to protect myself and my team from stress. Because that's my hidden job. Because dentistry, let's face it, anytime you touch a patient to do anything, even a filling, it has the potential to go wrong. And I don't think many of our patients factor that into how stressful our job is on a day-to-day basis. We are taking huge risks every single day with our happiness, to take on cases like this. So I sat down with her and I told her what the gold standard procedure was, you know, the orthodontics, the guided bone regeneration, the soft tissue grafting. She said, money's not an option. She said, I'm very wealthy, I can pay whatever. And then I kind of understood that this was a patient that if anything went wrong, I'd probably have some stress. So what I did was I did a mixture of crowns and veneers, just lowering the contact points. So she ended up paying a lot less money, having her smile, which was what she really wanted at the end of the day, a lot faster in only 2 appointments, and she was out the door and happy with her life. So you can see here, the only thing that we did was we lowered the contact point according to the literature. And we've got quite a stable result. So is this cheating? Is it cheating? Is it cheating, Mo? No. I don't know if it's cheating. So, you know, for those of you that don't understand, in Europe, most implant surgeons are also restorative dentists. So I actually first trained in cosmetic dentistry and then in implant dentistry. So my brain kind of always tries to see the end result. But keep that in mind. Remember to save yourselves from stress. Sometimes it's just not worth it. So the way that I say is that every patient brings the same problem when they come to the clinic. And it took me years to actually break this formula down to 3 simple steps. They'll bring a clinical issue, they'll bring an emotional issue, and a financial issue. And quite frankly, if you can't get past the last 2 in the first appointment, then just don't go ahead with it. So that's pretty much a formula for failure. Make sure your patients, Raquel spoke about this, that you have empathy with them, because if you're going to do complex perio surgery to try and get back something so elusive as a papilla that has so much science behind it, you really want that patient to be a partner and not a client. And you want that mindset to change. So failing to address all 3 in the first appointment is a formula to a problematic relationship because, oh, you guaranteed that, or you said that I would have a papilla and now. And sometimes these people will go through their entire lives without papilla and you will literally improve it 90%. And they will give you so much headache for that last nanomillimeter that you didn't fulfill. And it's very, very tough to do these kind of things. So for example, this young gentleman appeared in my practice about a year ago. And he was very informed. He was a lawyer. And he said, I would like to have nice teeth. And he was very, very resolute that his treatment was 6 anterior veneers. Because, of course, he'd been to my competition or other clinics in Lisbon. And he knew a lot about veneers. And he just wanted to understand how much I would charge for a veneer. And I said, sorry, sir, but your treatment is not veneers at all because of everything I described. The teeth weren't adjacent to each other, the embrasure, the shape of his teeth. This was a landmine waiting to happen. So I said, well, my veneer are, let's say, for discussion's sake, $1,000. He said, okay, $6,000. And he put the $6,000 on the table. He said, come on, let's get it over and done with. Now, I showed you a case previously with cosmetic ceramics. We managed to bring the papilla down. But in this case, we know instantly that he'd have a very unappealing aesthetic result if we just did what he wanted. So I reached out to the DSD group in Madrid. I scanned his teeth. I sent it to Francis Coachman, who's Christian Coachman's brother. And we did the DSD protocol. And we shipped this back. We put it in his mouth. And we understood how much movement we'd have to do orthodontically previous to placing these veneers. And we took some photographs. And we showed, in real life what that would look like. And look, we've got papilla. This is just structure. It's bisacryl. It takes 5 minutes to do using 3D technology and, of course, great work from the DSD team. But this is like very fast. It was his first day. This is like 3 or 4 days later. And he was not convinced. He didn't want to use the orthodontics. He said, but I'll still give you $6,000 for the veneers. And, of course, I don't accept these cases. So in complex dentistry, it's more about me accepting my patients. Thank you. Than my patients accepting me. So it's the only area in my life where I'm a little bit arrogant, which is I'm here to choose you. And I tell my patients to their face. It's kind of like, imagine you're a lawyer. You want to be the district attorney. You can never lose a case. So it's about case selection. It's like, so as long as you realize that this job is not about making money, it's about avoiding stress for you and your patient, you'll all be happy. So here are a few other cases that we solved quite simply. by cheating, I guess, with some veneers and some ceramic restorations. And we have a 2-year follow-up. And it's very stable. Why? Because the biology and the mechanics support it, as the literature will say. So here we have a 2-year follow-up because we're respecting the contact point to the bone, good oral hygiene, etc. It's good occlusion, as cardiopodgia would always make sure of, because that would change the dynamic. And then we have this wonderful papilla. Honestly, what's wrong with that one? My mother, she's going to kill me. My mother has one of these. And you would say, well, why does your mother have a removable denture with an overdenture she has? Because when she turned 16 in Manchester, my mother is a redhead from Manchester, it was customary to go to your local dentist and have all your teeth ripped out and have one of these things put in. This is not my mother, by the way. And I was just, what a barbaric thing to do. Anyway, so millions and millions of people have these papillas in their mouth. And you know what? They actually have happy lives. And for a lot of my patients that come with a problem like this and say, could I please have biological papilla back? And we start discussing the second and third tier of their problems that they bring, which is an emotional and a clinical. So emotionally, everybody would want to get rid of a denture. But financially, can they afford it? And if they cannot afford this complex stuff, I would say, usually it's this poor old lady that's got all of her savings, her husband has died, and she comes and says, look, I can afford. And your heart breaks because you just can't do it. So I say, go on a cruise, buy yourself a nice dress. A good denture can also be an incredible way of being happy again. So I don't feel that I have to always treat these cases. But in this case, she was very happy to go ahead with what we presented to her. And this is another solution for papilla. And so we did DSD on this case. This case is already 2 and a bit years old. So the surgical planning was done again by Christian and his brother Francis. And this is what it looks like. I don't really get involved. And for those of you that are thinking of getting into digital dentistry, delegate. So I have a young team of very bright young dentists that grew up with cell phones in their hands that understand this language better than I ever could. So reach out to your community of young dentists and give them a job because they'll be happy to work for guys like you. So we did the guided surgery. This is one of my very rare all-on-4 cases. I was talking to my Portuguese colleagues, and in 21 years, I've probably had 8 absolute indications for an all-on-4. I much prefer to regenerate, but sometimes it's a good solution. And just did old school. And here's a great way to get papilla. So, of course, you guys and Coachman did some great articles on that back in the day, and it's an incredible way to get it back when getting the real stuff is going to be pretty impossible, right? So this is a zirconia infrastructure with stratified ceramic. And you know what? It works. It works. Patient is happy. Everybody knows this. When she's smiling, it works. So it's also a great way to get the papilla back. Then we have some other ways of getting the papilla back. Here's a similar case. In this case, we did 2 applications. We did some veneers. And here we did, I don't know if you can see that, because this patient didn't want to go through orthodontics. So we did a little bit of a study there, a bit of a smile design study, and we realized that we could get away with, this patient was adamant that he didn't want orthodontic or implant therapy. And we've got a 6-year follow-up here, and we've got some pink ceramics there. I don't know if you saw that in between those 2 teeth, and pretty happy patient. Again, this is a kind of complex case where we did an interdisciplinary approach with Invisalign and composite. Patient didn't want to afford, well, actually what we'd said initially was you're always going to need some work done on your teeth to change the embrasures, to change the anatomy. We always propose feldspathic veneers, but sometimes patients say, well, I don't want to actually have this on my teeth. Is there anything easier, simpler? We'll say, well, bonded composite always works, and if it doesn't work, we can then jump to the ceramics. And actually, this case was done with Invisalign, and my dentist, Inês, who works with me for 11 years now in the restorative dentistry department. And we have a very, very long follow-up. We've been using Invisalign for 14 years now, so we've got a pretty good track record with this. So not a perfect result, but you know what? She's got papilla, we fixed the overbite, and we did it simply and cost-effectively for this patient. And the same way that orthodontic extrusion, which I'll discuss in a bit, is a very good way, which of course was initially described by Team Atlanta. orthodontics is probably the best way to fix this problem. And in this case, this patient actually ended up losing this front tooth. We had to do some guided bone regeneration during the orthodontic treatment. And this is 9 years later. Here we have the implants, and the biology is stable. Patient is pretty happy. So these are not just, this is an implant summit. So these were non-implant solutions for the papilla. And of course, when we're talking about implants, the game changes completely. And funnily enough, Bernardo, you had a slide very similar to this. So I was kind of like, great minds think alike, because so much has changed in the last decade around implant therapy. So much, there's been so many different topics. And even over the weekend, we've seen new concepts and new things being presented. It's like nobody's sleeping on the job. Everybody's coming up with the next best thing that can help our patients get their end results faster. So, of course, it's been mentioned several times over the weekend. Tissue is the issue, but bone sets the tone, and it's all about the papilla. So again, it's Sunday afternoon. I'm not going to bore you so much with the science, but it's been discussed repeatedly over the past 2 days. We all know that after tooth extraction, and Bernardo showed this very well in his lecture. So we have bone loss on average is 3 to 5. Horizontal is a little bit more than vertical. And on average, tooth extraction in the anterior maxillar arch leads to vertical bone loss of about 2 millimeters. So between the 80s and roughly 2006, I would say that most implants in the world were losing bone. It was still a big discussion of if I'm going to have success or not. And I don't think an implant surgeon in the room today can say he's never lost bone around an implant. And my good friend Tomas Linkevičius and Algirdas Puigas from Lithuania, they've spent a lot of their career on focusing on the zero bone loss concept. And I mean, it's what we all aim for. And Alan, your work is absolutely outstanding. I mean, talk about no bone loss. It's amazing. So I've worked with several implants over my career. I'm always exclusive just because it's a headache to have several systems. So I always believe that I'm using the best implant for my practice and for my patient. And I've had some failures along the way, but mostly successes, of course. And we're all trying to figure out a way to make sure that we can have a zero bone loss, because that is the only way to make sure that our papilla is not going to disappear. So Albrechtsen in 1986 said the successful criteria would be roughly no more than 0.2 millimeters in the first year of function, which would mean by the third year, less or equal to 0.4 millimeters. By the fifth year, roughly 0.8 millimeters. That would be acceptable. So, and of course, Astrand then did a study regarding the Brunnemark implants, and we pretty much understood that the bone levels will most often recede to the first thread. And of course, I'd like everybody to give a big round of applause for Carl Misch, who unfortunately passed away this year, because he was a giant in implant dentistry, and that was pretty much standard. We know that if we'd lose bone to the first thread, that was actually acceptable. But of course, how would that relate to the papilla when we had a thin biotype? So many dentists had to think, they had to do an algorithm in their heads to where they'd place an implant in the aesthetic zone, already preparing for this planned bone loss. Of course, soft tissue changes in implants plays an important role in assessing the success rate in the aesthetic area. And I think this is one of the biggest discussions today in implant dentistry, which is implant design. And you all saw Professor Park's amazing lecture yesterday on how his design, the design of the Megagen implant, actually is it's all about preserving the bone. So any implant that actually focuses on the soft tissue and the periodontal ligament, I think, is something that you should pay a little bit more attention to. So crestal bone loss has been observed around the perimucosal portion of dental implants for decades. It has been described in the crestal region of successfully osseointegrated implants. So bone loss to the first thread was considered success. However, bone loss will most often result in peri-implant mucosal recession, which of course will then in return affect the aesthetic outcome. So this guy worked really hard. I don't know who did this case. It's not my case, but it appeared in my clinic, so this is my photograph. I mean, I'm certain that the surgeon that did this or the restorative really tried their best to the best of their knowledge. But of course, we know why this will fail. And we are actually treating this case as we go, and I hope to present this soon on Dental XP, so stay tuned.